Sheldon, what I hear is that Connecticut's creating a system where access is better. That the problem of access is being addressed by redesigning it so that patients have access. What's going to control the costs? Because the reason they moved to a managed care system and the reason that New York has gone to this managed care system was to control costs. So in the case of Connecticut, what's going to be done about controlling costs, or is it not a problem?
Okay. There are several answers to that. The first is that the assumption may be faulty. The assumption that you can control costs by contracting with a company that's paying a capitated basis has these assumptions of we're going to pay them less, and therefore we're going to, we'll see that difference. What we saw in Connecticut is, as I told you, we started at 95%. The pressure for a company to do any kind of minimal care delivery, given its high overhead, administrative costs, which includes marketing, it includes the prior authorization department, it includes profits, it includes executive salaries and bonuses, all that stuff. It's expensive. So it's tremendously difficult to do it at less than the cost that the state would pay. And then what happens is the HMOs, and I assume you'll start seeing this here, the HMOs start saying we need more money. So the assumption, that's what I'm saying, it's perhaps a faulty assumption. But in terms of actual cost control things we can do, one of them is that you can fully do prior authorization through a state-run system with the administrative service organization or not, where you do appropriate prior authorization. You look for areas where you know there's some overuse and where you can avoid some redundancy and look appropriately, not just for the bottom, not for the bottom line, but because you know it's inappropriate. And there are cases where that's done and done well. So I would suggest that could happen. And the third piece is if you truly coordinate care and you truly avoid complications, which are very expensive. Obviously, going into the hospital completely eats up whatever savings you would have otherwise had. That overall, you really can control costs, and there are other countries that do that, there are other places that do that, and I think we're going to see that happen.
Okay. All right, then, Diane, let me ask you, why, if the state has moved this way over the last 10 years, really, in the interest of cost, why hasn't, what pushback has there been from consumer advocates? I mean, consumers, your agency, Community Service Society, is a consumer advocate, and yet, where's it been pushing back against this, or either Community Service Society or other agencies?
So, the work we've done is, try to get the state to be transparent with what they, so for example, Sheldon spoke a lot about just the different rate structure. We weren't even able to get information about what the state pays managed care plans, and the way that I was able to become privy to that information was in a whole nother section of my practice around Medicaid fraud. I said, look at this, I just got discovery on this case. This tells us what this person's capitated rate has been. I mean, this is a major find for us. So, we've been able to, we have not been able to get information from the State Department of Health and the Division of Managed Care that we would like to. In past years.
Even from the nonprofit plans.
Yeah. Because the way that we're asking for it is not the plans themselves, but through the state. Mm-hmm. And they'll give us like their core reports, their quality measures are published, the different kind of, and I don't even know the acronyms for all the national organizations that certify the different plans, but just
NCQA.
Right. So those kinds of surveys that are done, but the information is coming from the Division of Managed Care itself. And for past, administrations, we've had a bit of a, harder time. Now we have a little bit of an easier time getting information out of them, but really it's about transparency in that division. And it's been a hard fight to get information about transparency.
Can I respond to that?
Sure.
Just sort of open discussion. We had this fight a lot, and they didn't want to, the capitated rates were public. But how much they paid the providers, that was top secret. You know, national security was involved, that was
Trade
trade secrets. And other areas of special criteria they use for various medical conditions where people request services. And what we discovered was this: make the request of the state very public, meaning you're very explicit. We need to get this information to know if the taxpayers' money is being appropriately spent or not. We know that you don't have the data, state agency, but you can get it from your contractor. So please ask for it, and it's a win-win, what we learned, because either you ultimately get it, or more likely you don't, and then it becomes a press issue. State agency, and frankly, what we did is, we didn't bother calling it the state agency. We said the governor. We said the governor does not want to be accountable for how much she is paying, or her people are paying to state contractors. That's our money. The taxpayers have a right to know that, and that's why I brought those editorials. You see that. This is a very powerful message that a state agency, and ultimately who reports to the governor, does not want to be accountable with the taxpayers' money. So I think that's the moral, is ask for it publicly, and you win either way.
Okay, open it up.
Wow.
Steve?
Connecticut is fortunate in having a governor who is from what sometimes is referred to as the Democratic wing of the Democratic Party. New York State currently has a governor who is from the real estate and Wall Street wing of the party of money. However, some Democrats and some liberals are loath to go attack him for a variety of reasons. You keep referring to her, of course that was Governor Rell, who was an official Republican, which made it somewhat easier. I'm just wondering how that will, if you have some suggestions for us dealing in New York State with a governor who is nominally a Democrat, but cut quite explicitly, there's really no secret about it, cut an official deal with fire insurance and real estate interests ahead of the election, that he wouldn't mess with their interests.
Well, I mean, I can answer that question easily, except for one piece you added into that, which is you said that some liberals and others don't want to attack the governor. If you didn't say that to me, my answer would have been, the governor is responsible. The message is that any governor who doesn't want to hold huge state contractors accountable for the taxpayers' money has a lot to answer for. So I would use, that is the message we used with Jody Rell, the previous governor. But for the political concern you raise, I don't see any reason why I wouldn't use that position here.
I want to applaud and amplify your comments here. Some of you know I'm Ed Anselm, and I serve as Chief Medical Officer for HIP Health Plan. After that, Fidelis Health Plan managed 600,000 Medicaid members. I know where to look when you finally get or begin to push transparency. But I want to talk about the real cost of Medicaid in New York State. And some of you may have read in the paper a few days ago about the fact that Diane Sheehan, the Inspector General for Medicaid fraud, had been released last fall. And apparently had been too effective in cutting the Medicaid budget. And you know, New York is #1 in Medicaid per capita expense, and certainly on the population base #1 as well. So there's some real reason for concern and some real things to look at. You know, given the lack of interest on a population base in media around this incident, the lack of response around this, what do you suggest for people who are really concerned, just from a taxpayer point of view? What value are we getting for the billions of dollars we're spending on the Medicaid program in New York. How can we establish accountability, fiscal accountability for what we spend?
Well, pay for performance models. You know, I do know that our state, their auto assignment, and you probably know this as well, their auto assignment algorithm supposedly, you know, they, to put it simply, they pay the people that do the best on these national standards, national health standards. And those people, those plans, get a higher, in the auto assignment algorithm, they get a higher percentage of kind of default members who don't choose. So that's kind of one way to pay for performance. But there are all sorts of other, you know, models out there.
I mean, political accountability. Clearly, there are ways to save money, and New York State is going to be a leader nationally in the advanced medical home and so on. That's going to be a great foundation. But how do you establish political accountability? Really, that's what the discussion needs to be for the huge amount of money that's just not being used well, and certainly not serving the interests of our citizens.
Maybe let me rephrase your question. Where's the advocacy in New York State that's analogous to what Sheldon's been doing?
Where's the infrastructure? Because I want to sign
I
on.
don't see it myself.
I'll help.
Well, I mean, you know what, if people want to sign on, that's really what we need. We need resources devoted specifically to these issues, because Sheldon can tell you that legal services organizations are overwhelmed with just general problems. And, you know, what legal aid and what legal services does is not just Medicaid, and all their resources aren't devoted to just making sure that Medicaid managed care isn't in your state. It's housing, it's public assistance, it's Social Security, it's a million health and welfare kinds of things, and the resources are very short for specific programs, and people are just kind of, you know, am I going to get on this policy? I mean, Heidi can speak to this. Am I going to get on this policy call, or am I going to make sure that, you know, my client gets her operation this afternoon? Sometimes that's where the line is, and so, you know, people who want to, you know, volunteer towards this effort, and really it's about money. Getting the money in there to people that are willing to do this work.
I mean,
Go on, Sheldon.
so I do just describe exactly the situation in legal services where we turn away so many people and how we spend, you know, how we spend our time. I'm the only person who does health access in my program for Greater New Haven, you know, I'm one person. So, you know, how did I manage to do this work? The answer is I have enlightened administration in my program that saw the problems of access to care, particularly for kids, that kids were going without really basic treatment, and it was really disturbing that something had to be done about it. And they were willing to say, you know, it's worth your spending your time on this, because in the long run, how many people are going to benefit if we change the system and we make a better delivery model? We're going to benefit so many more kids and their parents than, you know, fighting about the individual treatment, which I also do, I mean, on a regular basis. The other thing I wanted to mention about this, though, is that the insurance industry is extremely powerful, and they have got their claws into things. You know how they make lots of contributions, and those are just to be generous? Not exactly. There's something you get for that, and what you get for that is loyalty. So, for example, when we started that litigation in 1999 against HealthNet, one of the largest, the fourth largest insurance company in the country at the time, we saw all kinds of help from like foundations and, you know, and health foundations. And we said, this is really important. This is going to improve access to health care. They weren't interested. Well, you know, if you start looking at who's on the boards of various foundations and who donates to those foundations, it really gets difficult. So I certainly would like to see other states doing what we're able to do in Connecticut, but given the fact that funders have serious conflicts of interest, and the fact that, as you described, that the resources on when you're, you know, the non-profit organization trying to do advocacy, it really is a challenge. we need some angels, who are going to come in and swoop in the various states and support the advocacy.
And now I just want to respond to just a piece of what you said about health homes. So now there are all these other kind of smaller models that are being introduced, like health homes. And as far as I'm concerned, a health home does what managed care was touted to do 15 years ago. But now the state says, okay, well, the new thing to coordinate care is a health home, and each managed care plan will have health home providers who will get a bump. But really, a health home, it just seems to me that it's, it's exactly, we're kind of repaying for what managed care was supposed to accomplish a lot of years ago and has failed to accomplish for a lot of enrollees.
Alec?
The practice I'm in, I have an office in an assisted living facility. Every one of my patients is on Medicare, and 90% are off on Medicaid. It's an assisted living program, actually. And we're looking at these, and they all get essentially more than 120 days home care. The services we provide are equivalent to home care. So they are all going to be folded into these systems, in the future. And we're sort of looking at the changes that are coming as a combination of, it's going to range from either bad to catastrophic. We're not sure how bad it's going to be because we don't know all the details. We're still negotiating with these various organizations. And we provide a lot of high-level coordination. I'm there full-time. We have 2 social workers full-time who are there to do case management. But we think even with all this, it just seems that we're just going to have to go through a hard time, and the state is going to have to learn the hard way. We have an example right in Connecticut and God, even Oklahoma, and they learned this, and we still don't want to. We're still going in the opposite direction. We're going into the private HMOs at the same time that other places are withdrawing. So what is it going to take for people to realize this? And I think one of the things that explains this is that the same way many of the private companies look at the short run and not the long run, some of our political leaders are thinking of the same thing. They want to see this year's budget, juggled, and they're going to come up with some, way of doing it, some managed care thing. And by the time we realize 2, 4, 5 years down the road that this didn't work, even though everybody's predicting that it's not going to work in the field at least, by that time the governor will be where? He'll be in his second term as governor. He'll be running for president. I don't know where it'll be. But the thing is, by the time we learn it, it's they've gone on, and they've come up with they'll come up with some other plan to try to avoid doing just what you did in Connecticut, which is to go in the exact opposite direction.
Do you want to say something?
I just wanted to say, listening to all the complications, and you're the person who made this happen, it was a miracle. That's it. Phenomenal.
I can't help.
Did you want to say something?
Hi, I'm Nithya. I work in case management, HIV/AIDS case management specifically, and that puts me in a pretty interesting position because I'm kind of a liaison between clients, like the actual people receiving care and the people providing care. And this last year has been sort of just a whirlwind of all kinds of HMOs, the special needs plan, and I guess I missed some of the presentation. I apologize, but it's mystifying because at the end of the day, I had a client just recently who was auto-assigned into a special needs plan, and then all of a sudden she was supposed
on Medicaid?
On Medicaid.
There's no auto-assignment into a SNP.
There is auto-assignment into a SNP.
No, there's no auto-assignment into a SNP. That's not legal.
Okay, well,
So
perhaps, okay,
you
sure.
take my card.
Well, sure.
You're not supposed to be auto-assigned to a SNP ever. Because the states, actually, I was someone who thought that auto-assignment into a SNP for a person living with HIV or AIDS wasn't a bad idea. And the state's whole thing was, no, confidentiality, we can't do that. I thought it would be a better model to, keep people in kind of a very regimented system of care. But so You're never supposed to, nobody's ever supposed to get auto-assigned to a SNP.
Okay, perhaps,
Go ahead.
okay, sorry, maybe she
No,
wasn't
that's
on
okay.
SNP, but she's enrolled into a SNP, and, she was supposed to have a regular ambulette that took her to her chemotherapy appointment because she suffers from HIV, from AIDS-related dementia, and is not physically able to travel, and then once she got into the SNP, all of these things happened. Her ambulette wasn't coming anymore. She couldn't get to her chemotherapy appointments. We, as case managers, had to just be responsible to like navigate the bureaucratic, messy web of like different people to talk to be able to get her care. And at the end of the day, she didn't get that service that she needed. And it's really upsetting. And this is like, this happens often. We had someone that had to go through an entire winter and couldn't get a scooter because of all of the complications to do with the special needs plan not being able to cover it, and prior authorization and all that kind of stuff. So I guess I'm wondering, like, in the model of cutting costs, where do health outcomes figure in? That seems to be like something very central, I would think. So that's just a question.
So, or where's the movement that you could join and could respond to that kind of situation?
I guess the question. Sorry.
I'm Josh Lipsman. I was the Westchester County Health Commissioner, and now I'm a healthcare systems consultant. And I don't actually have a question so much about the strategy for change, which we could sit here and ponder all afternoon or evening, but more a question for you, Sheldon, about implementation in Connecticut. What role did health IT play, or does it play, in either the systems level or the practice level? What you've described seems like health IT would be an essential underpinning for the success of something like this, and you don't mention it at all, so I'm curious about that.
Well, the reason I didn't mention it at all is I'm going to make a confession here, which is that our discussion of primary care case management and our push to how to become a model as an alternative to the HMOs was utilitarian, because the idea was to get away from the whole capitated system, because the things you just described are inherent. That's the nature of capitated managed care, is that the entities that run the system are going to do these kinds of things. It's not bureaucratic. It's the point of the system is to make access difficult, because then you make more money. So we argued for primary care case management, at least initially, as a utilitarian thing to give an alternative to managed care. However, now that we're actually there, we've gotten rid of them and we're going to primary care case management, it's actually not called, they're calling something else. But the point is that as we're going to it, there are some specific requirements. So the medical homes, the primary care providers run, have to be NCQA certified as patient-centered medical homes, or they have to be in a glide path towards getting there. And the requirements under NCQA essentially require electronic medical records. It doesn't explicitly require, but the things that you have to do in order to get certification are going to be extraordinarily difficult unless you have electronic medical records. So the answer is yes.
Well, how about at the system level, like health information exchanges, RIOs, kind of statewide sharing of data? Would seem like a single
Yes.
ASO would lend itself to that.
And that is being built. It doesn't exist yet, but that is being built right now. In fact, the ASO made a presentation last week about just that. They gave a model of fake screens, but of how the model is going to work, where with appropriate consents, the primary care provider can click on the panel of patients they have and see, for example, all the visits that the patients have had with which providers and what dates, so that they, if you're going to coordinate care, you kind of need to know what your patients are doing, I guess. So the answer is yes.
Can I
Adam?
just
Oh,
respond
yeah,
to the
Diane?
local case manager for a minute?
Sure.
So, you asked like where are the kind of measurements of health outcomes? The problem is that, did you get your ambulette is not a question in terms of the NCQA, whatever the national standards. They're not asking recipients real-time questions about whether or not their care has changed since they were in fee-for-service and now they're enrolled in a plan, right? So there are all these kind of studies and measurements and tests that the State Department of Health comes back with with and says, but we do, our Medicaid program, every plan has to submit all this data that's run into all these reports that are produced, but nobody ever says, but did your HIV recipient with cancer get her amulet? And so that's where there's like a disconnect in the reporting of like adverse outcomes. Because there's no way to report that as an adverse outcome.
Is not getting chemotherapy an adverse outcome?
I don't know that,
Point, we have, right now in this week, we're advocating, the Assembly has put some language in for quality measures for managed long-term care. I don't have the bill with me right here, but they really want to look at, not just how many hours of home care are you getting, but what has the change been since you went into this managed care plan?
and this is something that that everybody has, the administration has failed to look at for these other.
So,
disabled
this is only in the Assembly budget bill, it's not in the governor's budget bill or the Senate budget bill, so we really need to try to build support for this, and we don't know if the Department of Health is gonna wanna do this, but, there is some language that we were carrying around actually yesterday in the legislature that would, that has a whole bunch of measures but that's what we're sort of relying on, is trying to get quality measures in to sort of counter this cost shifting. Right?
I think the other thing I wanted to say is that actually the State Department of Health, after SSI recipients were mandated, we pushed them for more provider training and more recipient training around the change. The HIV population, as you may know, is a lot more kind of a cohesive advocacy group than years before SSI recipients. That could be various different kinds of disabilities. So the SSI population is much more cohesive, and they actually hired a private firm to do training for all COBRA case managers on the change and kind of what the change was going to look like. We try to get them to put in some slides about what transitional care means and how a COBRA case manager could actually be an advocate in this sort of scenario. And their slides were what they wanted their slides to be. But I feel like specifically with the HIV fight, we won a lot of things that we weren't able to win with past disabled populations. So I would love to show you my training materials on what you do when somebody is newly enrolled in a SNP and can't get care. Because if the plan says I won't pay for this, especially during the transitional period because it's out of network, that's illegal. And if the provider won't, the provider must agree to bill an out-of-network plan and know how to do that. And so that's where your advocacy can come in, or our advocacy can come in and should come in. And, I'd like to say, too, that I received still being in the legal services world during that, the carbon of people living with HIV and AIDS, like I said, I received very few complaints about the carbon, and they were specifically about marketing. And I'm always one to say, it's the very together consumer that actually gets to me. If there's millions, there's 4 million Medicaid recipients in New York State. 1 million are going to be newly enrolled after Medicaid redesign. If a handful of Medicaid recipients get to me, they're the savvy ones, they're the lucky ones, they're the ones that already have an advocate to funnel them to me. And it's those others that don't get to chemo.
Okay, Adam and Jay, and then I think we'll have to close.
One of the things I'm struck with in the conversation, what it is they're promising. In the outside of Medicaid world, we see a lot of problems both in the for-profit, but also in, to a lesser extent, the non-for-profit insurance companies.
From a consumer perspective, in terms of just, do people have less complaints about the for-profit than the non-for-profit? I would say no, there's no real difference in terms of like problem clients. Do I have more, clients that have problems with the for-profit plans than the non-for-profit plans? No, I haven't seen that in the past in my practice. In terms of cost savings of the managed care program overall, I don't know exactly what they are. I know that there has been some cost savings over the life of the mandatory mandatory program in our state. I know that, because we have so many, our Medicaid, our Medicaid population is so big and now aging so much and getting so much services, that, the cost of our Medicaid population is very high, generally compared to other states. But I don't know what the specific cost savings have been as a result of mandatory enrollment of the lower needs population. And then, we'll see now after MRC if it plays out fully, what the cost savings will be in terms of the higher needs populations. I will say that one of the things that the State Department of Health and the Division of Managed Care kind of touts is how their how Medicaid managed care plans fare in comparison to private plans, and in terms of kind of the quality measure outcomes and the like. And I think the point here is that Medicaid recipients are supposed to have kind of an extra set of rights that aren't available in the market. There's extra notice rights, like Sheldon spoke to. There's kind of extra access rights that are in the law, and then also built into the contracts that are different, and how people can take advantage of those and whether they actually have access to the broader protections is the question of the day.
Now let's respond to all three of your points, because anyone didn't ask for a comment on. In terms of isn't this just like insurers generally? I mean, the problems in Medicaid managed care is managed care generally. Well, I suspect in this room there's lots of people who would agree that maybe this whole concept of private insurance companies making profit, this whole thing doesn't make sense for the healthcare system at all. But even if you don't go that far, our clients are an extremely vulnerable group in terms of their medical conditions generally, but even the young healthy ones, in terms of education level, finances, obviously, even things such as being able to make phone calls during the day in a service job where you're not allowed to do that. Language, all the barriers that people tend to have when they're local folks, when they're our clients, becomes a much bigger problem. So as much as you have to fight with your insurance company to get what you need, if you're a well-educated, middle-class professional, you're going to be able to do a lot better than a lot of our folks. The second thing is with regard to profit versus nonprofit. I would say that in Connecticut, our experience was that, I sort of alluded to this, that our one of the last three, the one homegrown nonprofit did a little better. And keep in mind, it did not have to eat up 10 or 15% for profit. So there's a little bit more money to play with. Right? And then the third point, which is none of my business, which is whether it's saving money in New York or not. Let me just tell you, in Connecticut, for years, we were told we're contracting with HMOs because they save the state a lot of money. And a lot of people believe that. Some advocates believed it. And it took some work to start digging in and seeing that. And one of the things that happened that was really, I mean, you don't want to hear war stories, we're trying to end up here. But one of the things that happened was that, so we have a waiver, right? You can run Medicaid managed care through a waiver or not. We ran through a waiver. The waiver requires cost effectiveness. Cost effectiveness relative to what it would be without the HMOs. You do, okay. Our governor proposed a special tax break for the HMOs. What? Why are you giving a special tax break? And at a public hearing, we got questions, legislators asked questions, and we got the budget chief to admit, well, we have to give them money this way, because if we increase the cap rates, we might run afoul with the feds, will require cost neutrality. So he's basically admitting we want to prop them up, even though it costs more than not having them, and so we have to come up with a creative way to do it. There's all these newspapers, this is public information, but I'm just telling you, I mean, that's how crazy it gets. So people believe stuff that they're saving money. In the end, it may simply not be true.
Okay, Jay, and then we'll have to close.
I just want to really thank you for coming here and explaining this phenomenon that's happened in Connecticut, because I've watched this state going in the opposite direction for the past 10 years, and it is infuriating the number of people who are suffering and dying because of this political corruption. And I just just wanna name the problem. It's a political problem. It's not a policy problem. It's not that we don't know what works. We have plenty of ways to improve the system. It's a political problem and a political corruption problem. I wanna know, where is the state attorney general on this? Where are the investigative agencies that we are paying every day to look into why our citizens are dying every day for a few damn lousy dollars in the pockets of these corporations? Now this is an outrage. Where are our public servants on this? And I don't understand why we don't demand that. I don't understand why people sit passively while these things go on year after year after year, and people like Cuomo send me emails about how he's going to save money. He's going to save money, and it's going to come out of the blood of these citizens. Now, I can't stand the suffering. I want to know why we haven't done anything so far. I want to know why we have been so ineffective all these years in a blue state, in a blue city, with all the damn money in the world being generated a few blocks downtown. Now, where is that going? Where is that going? I'm sorry. Somebody please answer me.
The problem is clients with problems. If the State Department of Health, they have a hotline of call and have a problem. I have had numerous hundreds of clients that I bring to their attention to try to effectuate policy change. If you don't bring real people to them to say there's a problem, they think there's no problem. I have.
The problem is that Governor Cuomo is bought and paid for from before the election by the Committee to Save New York, and that is his sole constituency. The problem is we have an allegedly Democratic governor with national aspirations, who thinks he's got national aspirations, who is acting as a de facto Republican. Politics actually matters.
It didn't begin with him, and it was going on way before him.
Yeah, it was going on before.
Yeah, that was Pataki.
We have to close. It's clearly been a fascinating